Jennifer Adam. Before we begin, I see a few new faces here this morning. So we have Colin Neal, who's a new NHS member. Welcome, Colin. And we've got Willie Payton, who is the carers representative. So welcome, Willie. What we maybe will do is just run round everybody just for introductions, because I appreciate there's a lot of faces in this room this morning. So we start with yourself, Ian.
I know Willie well. Ian McMillan, I'm one of the councillors who's a member of the IGB.
Yep.
Colin Neal.
Could I just ask members to put their microphones on so those at home here? Thank you.
Yeah, if I could just clarify for everybody that's in the chamber, and it's maybe the first time they've been in, because we're conducting this as a hybrid meeting, we've got people who join us remotely. If you don't turn your mic on, then you won't be heard by anybody at home, because any other mics in the chamber will not pick up voices at that kind of distance. And as soon as you've spoken, if you could turn your mic back off, that would be helpful. It's simply the left-hand button at the bottom of the mic stand. Thanks.
Okay.
Lisa Marie Hughes, I'm also a councillor.
Morning, I'm Karen Jarvis, Chief Nurse in the HSCP.
Morning, I'm Stuart Sutton, GP Clinical Director of the HSCP.
Morning, Lisa Cameron, Social Work Manager, Service Manager for Locality Services.
Morning, Pauline Robbie, Interim Head of Service for Health and Social Care.
Good morning, I'm Karen O'Byrne, I'm the Head of Health and Social Care.
Morning, I'm Laura Howitt. I'm Head of Mental Health, Learning Disabilities and Alcohol and Drug Recovery Services for the HSCP.
Hi, I'm Paul Higgins, Podiatry Service Manager and Professional Lead and Lead HP for the hosted for HSCP.
Hi, Frances Burns, Head of Strategic Planning and Health Improvement in the HSCP.
Morning, I'm David Fogg, the Strategic Lead within the HSCP.
Thomas Patterson, Service Manager on Contracts and Commissioning, HSCP.
Good morning, my name is Willie Payton. I'm the Deputy Carer Representative on behalf of the Carers Centre in Renfrewshire. It's my first time at the meeting.
And Danny McCallion from the Renfrewshire Local Authority Unison Branch, deputising for John Boylan.
I'm Elaine Curry. I'm one of the committee services team in Renfrewshire Council.
Mark Connigan, Head of Corporate Governance at the Council and Clerk to the Board.
Good morning, I'm Christine Laverty, Chief Officer.
And I'm Sarah Levis, the Chief Finance Officer.
Okay, so you're very welcome, new members. We'll start with items of business. So the first thing is apologies. Do we have any apologies intimated, Mark?
I've received apologies from Karen Turner and John Boylan.
Okay, thank you, Karen. Okay, do we have any declarations of interest or transparency statements? No, we're all okay with that. Right, so the first item of business is the membership update. So what I'll do is I'll just bring in Mark. Oops, sorry. Oh, right, sorry about that, Fiona.
Yeah, it's just to declare a connection to item 11, just to put it mentions the Renfrewshire Head Injury that I worked for the organisation that used to provide the service. So it's just a connection, thanks.
Okay, thanks for that, Fiona. Oh, I see you, Ian.
Just to point out to members that my daughter works for Quarriers, but I don't think it stops me from participating in any debate. Thank you.
Thanks for that. Right, so we'll just move to item 1 to Mark, the membership update.
Thank you, Chair. Apologies to members for there not being a written report in respect of this matter. That's because I was seeking to clarify one issue around appointments, and I'll come back to that in a moment. In terms of, in terms of the appointments that have been intimated to me, the NHS Board have intimated that Mags Kerr has been reappointed as a voting member on the IGB with effect from the 1st of July 2024 for a period of 3 years. Kath Cooney and Karen Turner have been appointed as voting members of the IGB with effect from 1st July 24 for a period of 3 years. And Colin Neal has been appointed as a voting member with effect from 27th August. I would point out that's the matter that I've been seeking to clarify with the Health Board, the assumption within the order which covers appointments and indeed the IGB's own scheme is that it would be non-executive directors who would be appointed as voting members by the Health Board. Colin's an executive director. That is permitted in certain legal circumstances, and I've just been seeking written clarification from the Health Board just to have that confirmed. As of this morning, I'm still waiting on that, but I don't anticipate that being an issue going forward. That is just a simple email that I'm needing back. I've also had confirmed to me that John Boylan will be continuing as one of the Category 3 members. And other than that, I believe there are a number of outstanding positions that are still to be filled that I haven't had appointments for. If there are any other names that come forward to me, then I can obviously bring back a further report at a later date. Given the changes in the Health Board membership, that does mean that there is an additional item of business in terms of the Health Board specifying who they wish to be appointed as their Vice Chair, and that could potentially have a knock-on in terms of the IGB appointments. So I would ask the Health Board members to confirm who they would wish to appoint as the Vice Chair of the IGB.
Okay, Mags, I see your hands up.
Thank you. It was just to clarify in terms of the non-executive versus executive position. The Renfrewshire IGB previously had an executive. Linda de Casteker was the Public Health Director who previously sat on the IGB and was an executive director. So Colin coming in as an executive post is not new for Renfrewshire IGB. So it was just to clarify that point. Can I also make a second comment just around, I had understood that there was going to be a proposal at this meeting in terms of membership of the Audit, Risk and Scrutiny Committee, but that's not been picked up either.
Thanks, Mags, but that would depend on what happens in relation firstly to the Health Board's appointment of their Vice Chair going forward, so that needs to be picked up first. And then we can move on to the question of the Audit, Risk and Scrutiny Committee. Go back to your first point. I can't comment on previous appointments to the board when I wasn't specifically clerk. However, it may well be that the clarification that I've sought was provided to the then clerk of the board. I would have expected it to have been done so given the terms of the order, the statutory position which covers appointments to the IGB.
Christine just wants to come in to clarify a few things.
Hi, Mark. I'm not sure what's happened, but I've certainly got a copy of an email that was sent to you on the 17th of September on behalf of Jane Grant, and that does give the explanation and some background around appointing IGB members. So I can certainly forward that. I'm not sure if maybe the email address for you was...
No, I have that email, Christine, and I replied to it last night asking for further clarification because it doesn't answer the specific point. I didn't want to canvass all of this in the open meeting. The legal position is that in terms of the order, the specific wording is that the Health Board must appoint non-executive directors if they are unable, and that's the test that's set out in the order, if they are unable to appoint a sufficient number of non-exec directors, then they can appoint a minimum of 2 non-execs and they may keep the rest up with what is described in the Act as appropriate person. Certainly spoken to Colin this morning, I have no difficulty that he meets the test for an appropriate person under the Act. But what I need is confirmation from the Health Board that they are, and it is a very specific test, unable. So the email I received on the 17th certainly sets out a background which would, I think, indicate why they may be unable, but no one has as yet from the Health Board told me that they are unable to appoint the sufficient number of non-exec directors. That's the only confirmation I'm looking for. It's basically a one-line email that I'm needing back. Thanks.
So can I just ask for any nominations from the NHS board directors?
It was silent there. I don't know if anyone was speaking before that, and I'm waiting to come back in on Mark's points there. Please, Jennifer.
Okay, on you come, Max.
So I suppose I just want to reflect that I'm really disappointed we're having this discussion in a public board meeting. Colin is absolutely an appropriate member. The Greater Glasgow and Clyde Health Board are in a very unique position across Scotland that it has to satisfy 6 health and social care partnerships across the non-executive membership. Within that, and I won't breach any confidentiality, we have particular circumstances at the moment that means we don't have full complement of non-executive membership. That is why it is appropriate at the moment for Colin to be appointed. He is capable, he is a board member of the health board, and therefore it is appropriate. I feel we're playing with words if we're just waiting for a one-line email from the board when you've had communication from the board chief executive for the reasonings. So I just want to record that I feel it's I think we should have dealt with this in private in advance of the public meeting.
Okay, Max, thank you. Your comments are noted. Can I ask for any nominations with regards to the position of Vice Chair? Can you hear me now? Right. So I was saying, Mags, that your point's noted there, and I was just asking for any nominations with regards to the position of Vice Chair. Mags, you want to come in?
Yeah, again, I'm really disappointed because I had fully expected there to be a paper tabling this properly. So I've not had the opportunity to speak to Colin directly at this, and I didn't know that 2 NHS members were not attending this morning. So this is not a very helpful way to approach the membership of the IGB. I had been under the understanding that I can't hear what's been said.
Sorry, thanks, Max. I was just saying to asking the convener if I could come in. Sorry, I do apologise. I wasn't aware that there were 2 members of the health board not in attendance today. Otherwise, I would have invited nominations. I'm quite happy to bring further report back at the next meeting that will cover that particular point. On your point about public discussion, I agree with you. I was attempting to avoid to have that discussion. But it was necessary on the basis of the interventions that have been that happened in the course of the discussion. So on that basis, I would suggest that we move on. Yeah.
Yep, I would agree with that. Okay, so the next item is the minutes of the previous meeting. It's pages 5 to 12. I don't intend to go through it, but if you have any questions or comments regarding the minutes, then please intimate now. Okay, so we're all in agreement with the minutes. Okay, that takes us to page 13, which is the action log. The first item on that is the chair and the vice chair of the IGB and the IGB Audit Risk and Scrutiny Committee. So the report we submitted following the review of the integrational scheme. So any comments on that? Okay. The next item is the Renfrewshire Alcohol and Drug Partnership annual reporting survey. The report will be provided when details are available. It's on the agenda today. The next one, oops, Mags.
Really just to flag, a number of these are really quite old and due dates are past. It just doesn't feel like a particularly clear rolling action list to me in terms of the number of actions that come out of this board. I feel it needs a bit of a refresh and be clear on what the actions and timescales are, because some of these are over a year now and it's still not clear. So that's just a request for this to be clearer and updated, please.
Okay, Mags, that request is noted. Thank you. So the next one is a membership update, which we've just obviously discussed. And the last one is the Sustainable Futures Programme. The briefing will be delivered in future. IGB are to be briefed on and discussed with regarding self-developed support. So that will happen during one of our development sessions. So if that is agreed, the next item on the list is the Chief Officer's report. So I'll hand over to Christine.
Thanks very much, Jennifer. So as always, IGB members will be used to my report by now in terms of an update to the IGB on key developments and operational activity since the last time we met in June. Also additional policy developments that the HSCP is building into future work plans, strategies and our action plans. The contents of my update does reflect an ongoing period of change and challenge, particularly within financial circumstances faced by the IGB, and you'll hear a bit more about that as we go forward in the meeting. We also have given some details around key national policy for information for members. I do want to flag and highlight a couple of areas for members. The first one is delayed discharge performance. The First Minister has advised that reducing delayed discharges within Scotland is one of his key priorities, and as such a weekly meeting called CRAG, which stands for Collaborative Response and Assurance Group, has been set up and is chaired by the Cabinet Secretary. All Chief Officers attend alongside Scottish Government colleagues, Care Inspectorate and COSLA. Scottish Government have set a new target of a maximum of 34.6 delayed patients per 100,000 adult population. I'm pleased to report that Renfrewshire continues to perform extremely well in relation to delayed discharges with a current performance of 13.9 delays per 100,000 adult population, and that was at 19th of August, and we've actually improved a bit on that. We're into the 12s at the moment. So at that point in August, we had the lowest level of delays across Scotland and in the low category, which means that there's no performance improvement required other than sustaining our position. Just moving on, item 5 of my paper is an update around the new Bishopton and Dergable Health and Social Care facility. In April this year, work commenced and it's progressing as planned and within the current budget. Contractors are now fully on site with the installation of the structural frame, and timber kit has been concluded for the external walls. There is some detail around local artists that have been appointed to support the delivery of external artworks and the works underway around that engagement with the community, which will include local schools, GP practice and the wider community. There's also some detail at 5.3 around the anticipated completion date of summer next year, and that the new resource will provide much needed additional space for the GP practice, but also the health and social care practice, and provide some flexibility in how we deliver our services moving on. Item 6 begins to talk around the National Records of Scotland and latest publications. Item 6 is particularly looking around the deaths by probable suicide, and for Renfrewshire, it is a good news story, but we are not complacent that we've seen a decrease from 33 probable suicides in 2022 to 19 in 2023. We're always a year behind in terms of how this is reported, and I would want to say that even although that is a reduction in numbers, every death by suicide is an absolute tragedy. Moving on to item 7, again, it's the National Records of Scotland data that's been published on drug deaths. Unfortunately, that's not quite as positive for us that there was 44 drug-related deaths in Renfrewshire during 2023, and that was an increase from 39. And again, similar to probable suicide, every loss through, as a drug death is an absolute tragedy. And finally, as part of the publications from the National Records of Scotland, they have recently reported on alcohol-related deaths. And in Renfrewshire, a total of 52 people were recorded as having died as a direct result of alcohol in 2023. And that was an increase from 42 the previous year. I think certainly we've talked about this in a range of forums around not particularly being a surprise to us, given the impact of the pandemic and that many people turned to using alcohol and potentially drinking at home alone as well to cope with some of the challenges that have came out of the pandemic. Just wanted to highlight the review of social work governance, that the details at item 9 of my paper. The Care Inspectorate has launched a national review of social work governance and assurance across Scotland. And that was really, I think, given there's so many things in my paper that I'll stop there, but I'm happy to take any questions and anything that is in the Chief Officer update. Thank you.
Thanks for that, Christine. I see there is a few hands up. Fiona?
Firstly, thanks for a very comprehensive report in terms of the key areas that have been highlighted. I want to specifically look at the National Records for Scotland, the alcohol-specific deaths, because actually a 24% rise is really quite significant, and while we were predicting that there might be an increase, I'm not quite sure how that 24% benchmarks us against other areas in Scotland. I can see the figures are given in total for Scotland across, but I don't know whether that's a 24% where we benchmarked in terms of that. And also that at the time of writing, you said further assessment is being undertaken on the figures released, and I kind of was keen to know what would the further assessment compile of. It's just really concerning. 24% is a significant increase when it's alcohol related, or direct alcohol. Thanks.
Okay, thanks for that, Fiona. I'll just bring in Laura.
Thanks, Councillor Adam. Yeah, absolutely share the concern about this rise in alcohol deaths. And in terms of benchmarking, as we would expect, our figures are higher than some areas and lower than other areas. There was a small increase from a national perspective, but Renfrewshire's figures crept up beyond that percentage nationally. What I can do is provide a bit further information, Councillor Airlie Nicholson, post this meeting. I can email the benchmarking statistics to provide you with that information and answer any further questions you might have after that. In relation to activity, members will be aware relating to our own alcohol and drug recovery services and the work that's been done over the past few years in relation to drug-related deaths and harms. And that work has exponentially increased and grown over the years. And you'll be aware of some of that work as highlighted within Christine's report today. Similarly, working with our ADP colleagues, the ADP have appointed an alcohol deaths working officer for a fixed term period of a year to mirror some of the work that we have undertaken with the ADP relating to drug-related deaths and harms. So doing that deeper dive into, I guess Christine has drawn attention to the statistics and the data are just numbers. We want to actually understand the people behind the numbers and the statistics to understand their circumstances and do some of that analysis in relation to understanding what has happened in those particular cases. Were people in touch with services? If not, why not? What are our referral pathways? Are they working? And get some information from that will give us a clearer picture that we can work in partnership with the ADP to take that forward.
Okay, thank you for that, Laura. I see that John Goldie's actually got his hand up, and John is the chair of the Alcohol Drugs Partnership. So if I could bring John in.
Thank you, Chair. Yeah, it was really just to maybe reiterate some of the things that Laura had already mentioned there. But as part of the ADP, we were at a meeting with the Scottish Government just last week where all ADPs came together to actually begin to review those alcohol figures. Unfortunately, the picture across the majority of Scotland is very similar in terms of the increase in alcohol deaths. So Renfrewshire is not necessarily an outlier, but it is one of the areas with some of the highest figures within Greater Glasgow and Clyde. So the ADP is doing a number of targeted actions within Renfrewshire. Laura's mentioned the starting of the alcohol harems team, but we also have appointed two health improvement practitioners in conjunction with the health improvement team in terms of how we take a generic approach to alcohol, because a lot of the issues we have with alcohol are not specifically sitting at the door of treatment and care services as in terms of alcohol recovery services, although that's the most severe end. We need to be looking at our wider strategy for alcohol across all our HSEP and council facilities. So the ADP is taking a lead area in that over the coming months. And I'd be very happy to bring a report back to any future IGB in terms of the work the ADP is undertaking in terms of alcohol.
Thank you, John. That'd be very helpful. Right, I see Ian McMillan's hands up. Ian.
Okay, thanks very much. Again, a pretty comprehensive report, Christian, and I thank you for your work on that and bringing things to members' attention. It's the usual kind of mixed bag of some really positive stuff and unfortunately quite a number of negative aspects. Obviously, we've touched on the alcohol. You know, that's really, really concerning. 24% is a massive hike. It really, really is. And I know we've got a policy of the minimum price in Scotland for alcohol. Obviously doesn't seem to be working very well. And I've always got the concern that additional cost to alcohol goes into retailers' hands. I'm not aware of any of that money going into education, training, awareness, anything like that. I might be wrong, but I'm not aware of any of that extra money going into those issues. I'd like to ask that question. Obviously, the suicide rates, yeah, you know, it's fine. It's been down, but it still happens on a regular basis. And somebody who lives and represents a community where suicide sometimes is the only way out for some people, or they see it as the only way out. Having seen it myself and the fallout that has for families is obviously devastating. I see that you've mentioned the National Care Bill. There seems to be growing opposition to that. Although having been at the COSLA conference last week, it's very much a kind of showpiece policy of the government to pursue this, despite opposition from a number of people, professionals, politicians and trade unions. Again, really great about the discharge. I think that's fantastic. I think we have been really at the top of our game for a number of years. And sometimes it takes a lot of hard work to get to the top of the league, if you like, but even harder to stay there. So well done to all the staff involved in that, and pleased to see also the health centre at Dargavel moving ahead. I'm sure that will be welcomed by the community out there. Just a couple of wee things. Well, the last positive thing I would like to talk about, I'll write it towards the end. It's talking about carers, and I see there's further reports to see how we can improve services for them. So that's to be welcomed. Two questions. I just would like to know, I was speaking to one of the members in Bridge of Weir earlier on today, who was saying that the mobility bus, the bus that provides health services in that area, has broken down and it's not there at the moment. So can you maybe just give me some indication when that's going to be repaired and back doing its job? And the other question I've got is at 14.4, Christine, where you talk about instability of leadership within IGBs. Can you maybe just tease that out a wee bit more and tell us what you actually mean by that? Thank you.
Right, first of all, I'll bring in Mark to answer your question with regard to the alcohol.
Thank you, Chair. Thank you, Councillor McMillan, for the question. With wearing another hat, I'm clerk to licensing board, and it's my staff that enforce the minimum unit pricing aspect. So minimum unit pricing was set at 50p. I can't remember when that was brought in. It is due to increase to 65 pence per unit at the end of this month, which will push up the cost. I would suspect, albeit I've not seen any statistics which would confirm this, but given the movement of inflation over the period of time from when the minimum unit pricing was imposed, clearly any deterrent effect that was in there has become less over the period of time, and obviously that's why there has been a decision to increase the charge. But in relation to where the funds go, you would be correct that what happens in respect of the minimum unit pricing is that the Scottish Government don't have the power to be setting alcohol-related tax levies. They therefore chose to introduce a scheme which mandates a minimum price, but all of that money goes to the retailer. So if the cost of the minimum unit pricing is higher than the cost of the retail would otherwise have been, retailers are obliged to put their prices up, not sell at that at the cheaper rate. And that's often why you see adverts in the television and it will say it doesn't apply in Scotland in small writing at the bottom when it's discounts. It's because the discounts would take them below, but the money goes to the retailer. So it is increased profit for the retailer without it coming back to either the UK or Scottish Government in any way that would allow the funds to be redirected.
Okay, thanks for that, Mark. And I'll bring in Stuart, Clinical Director, with regards to the bus.
Yeah, thank you very much. So the bus is operated by NHS GGT centrally. There's been a mechanical issue, is my understanding. It's due to be back on Monday, but that's a public holiday, so it'll be a week tomorrow, the 3rd of October. We'll be back. A week tomorrow, 3rd of October, a week tomorrow. Yeah, next week.
And then I'll bring in Christine.
Thanks. So the comments about the leadership at 14.4 is in relation to the Audit Scotland report. So Audit Scotland had said that there was some uncertainty and instability, and from that I took that there's quite a turnover of chief officers across Scotland, and that's why they made that comment.
Okay, I see Mags, you've got your hand up.
Thank you. I just wanted to pick up on the National Care Service status, and that's open for comment, or it was open for comment until last week. I understand that the council is submitting a response on that. I haven't seen that, but understand that the council is, and likewise the NHS board has collated comments on that. I guess it's just to record that this IGB hasn't responded directly on that consultation, and that comments should be fed in through the partner bodies. My observation is that the nature of the questions are quite narrow, and I think we have to be very robust in how we respond to any future requests for information, because it could easily be interpreted as support rather than detailed concerns that do exist at service level and community, because it doesn't feel particularly clear at this stage, and to ask questions about something that is not clear, then actually the responses can't be clear, and then that is being used as a false positive. So I am quite concerned about that.
Yes, okay, thank you for that, Mags. I'll just bring in Mark.
Yes, thank you. I would have some sympathy with the comments that are made by Mags there. I can say that Renfrewshire Council have submitted a response on the National Care Service consultation, and given the way that the questions were framed, the council's response doesn't actually simply fit in with the questions. It went wider to provide comments on some of those areas, and reflect the council's previous view about its concerns about the NCS proposals. That was agreed, I think it was at the leadership board just a week and a half ago or so. I could circulate that if members were interested.
That'd be helpful, Mark, thank you. Okay, do we have any other questions or comments on Christine's Chief Officer report? I'll just move to the recommendations then. If we can agree to note the range of the HSEP key updates and the national policy updates, sections 14 to 18. Agreed? Okay, that moves us on to item 5, which is the financial report. So I'll hand it over to you, Sarah.
Thank you. I won't go into too much detail. There's a lot in the report, so I'll just highlight some of the main issues to note for members.
So similar to other IJBs across Scotland, the position is one of intense financial pressure, and you'll see that from the projected outturn, which is just over 8 million for this year. That is slightly less than what we had anticipated in the March 2024 budget planning. However, I don't think we can assume that that position will remain. We haven't yet had winter, and that can always have an adverse effect on the financial position. So at the moment, the projected outturn is 8 million, but I'm not convinced that that will remain at that level throughout the rest of the financial year. In section 3.3, I've highlighted, as in previous discussions with the IJB, the fact that as part of the annual accounts, we've had to reflect a contingent liability in respect of the backdating of monies due to care at home staff for the regrade. The implication of this is not yet fully known, as there are still some regrades to be finalised, and we're working with the trade unions to do that. But that's hopeful that that will be completed in the very near future. Another area that I would wish to draw everyone's attention to is in respect of the prescribing position, which is currently sitting at about 2.6 million of an overspend. That does assume delivery of some savings targets, specifically board-wide targets, and we're working across the board with other HSEPs and all of our prescribing and GP staff as well. So we're linking as best as we can to deliver a substantial amount of savings. However, that's very much dependent on the market and the prices attached to these specific drugs. But we are working away as hard as we can for cost avoidance and also to deliver savings where possible. But that, as you would imagine, is not always possible within prescribing. The other area to draw attention to is Scottish Government funding. So one of the areas that we are funded for is mental health outcomes. And this year, the Scottish Government have changed the way that they're allocating the funding for that. However, it came in a letter at the beginning of July, and when we analysed the letter as CFOs, it was very clear that the way that the calculation had been done was quite prohibitive to a number of counts of IJBs, and others were benefiting. So after much discussion, quite heated discussion with policy teams within the Scottish Government, they have agreed to reissue the allocation. That should be out this week. However, there will still be a substantial reduction in that for Renfrewshire. What that will mean is not yet clear. We await the letter, but we will need to work with the other 5 IJBs to agree how we're going to take this forward, because it will be quite a substantial reduction in the overall funding. And this affects Action 15, it affects CAMS funding and perinatal funding as well. So it's quite a big issue for us. So we will be bringing back revised plans to the IJB for information once that's been agreed. The final area to note is in respect of reserves and a proposed increase to reserves. This is just for transparency. If you'll remember in the budget paper that went in March, how we were going to deliver break-even this year included the use of the non-recurring reduction to the superannuation contribution. And just to keep that clear, we want to move that from the mainline budget into reserve, so you can see exactly where it is, and it will form part of the overall funding to deliver the balanced budget at the year end and will be drawn down. So that's in here for members' approval, just to ensure clear transparency of the position. So happy to take any questions. I do realise there's a lot in there, but and it isn't good news, I'm afraid, and is likely to continue in this trajectory for the rest of the financial year.
Thank you, Sarah. I would just like to say, obviously, in 3.3 that I welcome the increase in our care at home staff. I appreciate it's coming out of reserves, but our care at home staff are our frontline workers and they really deserve it so much. I know they've been battling for years, so I'm delighted to see that. Prescribing always is eye-watering when you look at how costs can fluctuate. And what's more astonishing to me is always the fact there's no overarching body that regulates them. You know, it's all based on demand and short supply. So challenging position that we're all in. But I see there's a few hands up. Ian McMillan, bring you in first.
Thanks. Just a few issues here. There's no doubt that the cuts to IJBs directly from Scottish Government are obviously taking its toll. I think it was 9%. I don't know if it's this report or another report. Sometimes they all blend into one another when you're reading them. That's obviously a worry if it's continued to get cut from central government. Question I've got is, well, one of the other comments I've got is about the postage. You tend to think, well, I tend to think it's minimal costs, postage, but it's obviously big enough to be highlighted in this report. We all know that the first-class stamp price of that has absolutely rocketed, so it must be an integral part of the costs that we're having to endure at the moment. So can I ask if there's any thinking about how we can do things better rather than sending out letters? As somebody who's quite protective of the Royal Mail, but the costs are absolutely huge. So is there other ways that we can deal with things? And I know probably the answer would be with more sort of digital and text and stuff like that, but I know there's some people, maybe that's not a thing that they do. But I just wanted to know the thinking about that, and maybe ask Sarah how concerning is about the pay. We all want to see our staff getting paid a decent wage, of course we do, but there's obviously a concern when it's maybe not properly funded, some of these increase. And the last thing is the prescribing. I know we get regular reports about the costs of prescribing, and John Miller sent us stuff this morning, as he does every morning, and which I really appreciate getting that information about, talking about there's been some sort of messages sent to doctors about you can be mindful of what you're actually prescribing, and I think there's a lot of stuff being sort of taken off the list of what they can actually prescribe. So can I maybe get some kind of thinking behind that, and how big a contributor to overall cost is maybe the needless prescribing of stuff that maybe you can get in the shops and stuff like that, and if that will be, it's hoped to be a significant cost cutting exercise. Thank you.
Right, I'll bring Sarah in first to answer your questions.
Yeah, so in respect of the postage, that mainly sits with the primary care side of the house in terms of screening. So when you have to send out all of these packages for screening tests like bowel cancer, etc., that relates to that. Plus, they also have to have a lot of recorded delivery. So they do what they can to do via email, etc. But as you know, a lot of that has to go through the post. So it's actually an area that we have been focusing on as part of Sustainable Futures, but there is a limit to what you can do. But the increase in the postage costs are eye-watering. So it's a really big issue. I'm not quite sure how we can resolve that. So it is something that we're aware of. Within the main IJB services, we try to use as little postage as possible, as you'll be aware, but for screening, that we really have no choice. In terms of the prescribing, probably Stuart would be best to answer that one.
Yeah, so I think the key issue is probably not prescribing things that people can buy over the counter. I think there is perhaps mileage in asking people to purchase things where they're able. I think in a cost of living crisis, and when we've got the option for people to go to a pharmacy and get medication from the pharmacy under Pharmacy First for free anyway, that still hits the HSCP budget anyway. So I think it doesn't really make a difference whether it's prescribed or whether people get it from the pharmacy direct. I think the really important work is the work on polypharmacy. So particularly people who've got multiple conditions, who are on multiple medications, making sure they're having regular reviews, they're only on the medication they need to be on, and that's the work the pharmacy team are doing, focusing on care homes, for example, at the moment, where you've got many people on multiple drugs, many of whom, if we review those and consider the need for them, you potentially could reduce those. And also really focusing time on the efficient prescribing switches, so moving people from a medication, for example, anticoagulants, blood thinners are the one at the moment, which is potentially going to have the biggest cost saving, really spending the time to work with patients to explain why we want to change them from medication A to medication B that has exactly the same effect, is just as effective, but costs the NHS maybe a tenth of the price. So certainly some of them we can treat 10 people for the same cost as treating one person. That all takes time because you need to explain that to an individual, because obviously if you are told we're going to change your medication, it's not something people want to just get a letter about and it's been done. Some of them require blood monitoring and assessments as to whether the new medication is kind of necessarily appropriate for them, because there are small numbers of exclusions. So I think, as Sarah said, that the work is underway, and I think that the areas have been identified where the maximum saving is possible. And I would say most prescribing clinicians, be it doctors or kind of other colleagues, so nurses, pharmacists and others, will be thinking carefully before writing a prescription, because I think everyone is very aware of the cost we've got at the moment, but we are pushing as much as possible on those really big big ticket areas where there's potential big cost savings to be made without impacting individuals.
Thank you for that. And now I'll just bring Sarah in to answer your question regarding the pay awards.
So our assumption at the moment is on the health side of it, the 5.5% has been agreed, and the Scottish Government have said that they will fully fund that, but that remains to be seen. We'll wait until we get the allocation from the Scottish Government, because there's likely to be some shortfall in how they calculate the allocation to ourselves. In terms of the local authority, that's not yet been agreed. However, I think there will be some gap in the funding that we'll get from the Scottish Government and what we've actually built into the budget. But until that's actually agreed, it's not clear what the impact of that will be on our baseline. But I don't think it will be too positive. Sorry, that's not particularly helpful because we don't yet know.
Okay. Right, thanks, Fatima. Do we have any other questions or comments on Sarah's report? No? So I'll just move to the recommendations, and that's to note the in-year position as at 31st of August 24, note the projected year-end position 24-25, and approve the proposed transfer to the earmark reserves in section 8.6.1 of this report. Is that agreed? Excellent. Okay. Now, the next item on your agenda says IGB audited annual accounts, but if I could just bring Mags in to give us a bit of a verbal update. Obviously chairs the Audit Risk and Scrutiny Committee, and she can give us a bit of reassurance about what's already came through the board. Mags, would you like to come in?
It doesn't make sense, I guess, for Sarah to introduce the accounts first, rather than, do you want a full update on audit risk and scrutiny, or just on the audit piece?
That's fine. Sarah can go ahead and do the accounts.
Okay, so in front of you, you have the annual accounts which were submitted to the Audit Risk and Scrutiny Committee on the 13th of September and for noting, and they come to the IGB for approval and for signature by the relevant people within the accounts. So I think for me, it was a very positive audit, and the annual audit report that came from Ernst & Young was very clear on what the ask of the IGB will be in the future. The way that the auditor carries out their judgments on our financial arrangements is on a RAG-based assessment, and they take into account internal and external risks. And for 23-24, we've been rated green in 5 out of 6 areas. That is financial statements, going concern, financial management, vision, leadership and governance, and use of resources. And as you would expect, we do have 1 red, and that is in terms of financial sustainability. So in summary, the external auditors had only 1 specific recommendation for the IGB, and that's an urgent need to develop a sustainable financial plan. And you'll see that that's a theme throughout the accounts. It's a theme throughout the Audit Scotland report. It's everywhere. So this isn't something that I didn't expect. So for me, it was a very good report, a very positive and very clear report in terms of the processes that we have in place. There was very little change to the actual accounts from the ones that you saw in June. They were really minor ones, more presentational. So again, the only thing that I would mention again within that is the fact that we have the financial sustainability issue that is just everywhere at the moment. So I don't really have anything else to add to the accounts. Happy to take any questions that anybody has on them. I think that's probably the best summary that I could do.
Okay, thanks, Sarah. Do we have any questions or comments on the annual audited accounts? No? Well, it just leaves me to obviously thank you, Sarah. I appreciate the amount of significant work that goes into this, in a very difficult, challenging situation. So if there's no commentary, then I'll just move to the recommendations, and that's approve the annual accounts for 23-24. For signature.
Sorry, I need to come in at this point.
Right, okay, Mags, and you come.
I didn't think it was appropriate for me to introduce audit risk and scrutiny before Sarah had actually introduced the accounts, but I think it is important that this committee understands the governance process, which is through audit risk and scrutiny, because clearly the board doesn't see the report from the auditors. That goes through audit risk and scrutiny, which we have had a number of discussions with the external auditors on both at planning stage back in the springtime in advance of the draft accounts being presented to the IGB, which you saw in June, And then we met on Friday the 13th to go through the annual audit report from EY. So that did align with what Sarah's described, and the report was overall very positive in terms of the quality of the accounts, and the committee did record our thanks both to the finance team and the auditors in terms of the work that goes into that, because it is a huge amount of work. We also had an opportunity to have a private meeting with the auditors just to confirm that they were not under any undue pressure to report in a particular way, and for them to have the opportunity to ask us if we're aware of any frauds or any irregularities. We're able to confirm that. The reason it's done privately is just good practice. We also had further discussions about the going concern of the IGB and to distinguish between going concern of the body versus financial sustainability. They are right to raise the urgent need around financial sustainability. That being different from going concern, because the reality is we would remain a going concern even in dire circumstances, because services would have to pause and be on an urgent need basis, and we have discussed that in previous meetings. So that was rightly raised. There weren't other control recommendations to highlight, so I guess the committee were assured that we could recommend approval to the board. And the previous actions in terms of our governance and training and some aspects of the admin around governance we have responded to, so those have been followed up.
Thank you for that, Mags. Okay, any questions, comments? We're okay with that. Right, so the recommendation to approve the annual accounts for 23-24 for signature in accordance with the Local Authority Accounts Scotland Regulations 2014. Okay, agreed. Takes us on to item 7, which is Sustainable Futures, and that'll be yourself, Frances. Okay, I'll bring Christine in first.
Thanks very much, Jennifer. I just wanted to say a few words before we hear from Frances. As we've heard from Sarah, there is an increasing demand for health and social care services, and the higher costs have created a worrying financial landscape within our health and social care sector across Scotland, but unfortunately this is no different for Renfrewshire. So as Chief Officer of the HSCP, I do have responsibility with the senior management team to advise the IGB on how it can deliver a balanced budget. And the prospect of the IGB, as mentioned by Margaret there, not being able to deliver a balanced budget is very real. And while the Sustainable Futures programme is very challenging, it is crucial that we do approach this in a planned way. And just finally, I wanted to give my heartfelt commitment to provide the very best services we can with the resources that are available to us. And I'll pass over to Frances. Thank you.
Thank you, Christine. Frances?
Thanks, Christine. So in line with what Christine has just highlighted, this paper seeks to set out a structured approach to how the IGB can address its budget gap. And the approach that's set out in the paper is in line with the direction that the IGB set at its meeting in June, which was informed by our learning, particularly over the last year in 23-24. It also reflects the challenges, the really challenging financial context in which we're operating, which has been already discussed today. And it also mirrors really what's been seen nationally and reflected in the recent Audit Scotland report on IGB finance and performance. Also importantly, the approach needs to take into account the very real capacity pressures and also the timeline constraints that we're operating in. So we're facing, in terms of capacity pressures, we've currently got 10% of our workforce establishment as vacancies, so 1 in 10 posts. We're also operating with high levels of staff absence, and also we've got a range of commitments in addition to sort of keeping the lights on in our usual operational business that we've got to take forward this year. And they're illustrated in section 6.1 of the report. But some examples of that is the revision. We're legally required to review our strategic plan. We need to update our participation and engagement strategy. We have a number of inspections going on as well, which place a huge pressure on our operational colleagues. So there is a real challenge to take this process forward alongside these, and as we've talked about in relation to delayed discharge, but in relation to the next item around a whole range of performance, how we continue to maintain performance. And it's really delivering, continuing to deliver the best outcomes we can for the folk in Renfrewshire. So one thing I would point out is that in relation to the approach that we set out, those capacity pressures and also the scale of the financial challenge and the amount of saving proposals that we are going to have to bring forward. I mean, we won't have the ability to do the extensive engagement that we did last year. However, there is learning in terms of how you carry out meaningful engagement and the way that we take that forward, which I'll talk about a wee bit more. And then the final point in terms of this approach, and I appreciate it is challenging, and it will raise anxieties among service users, carers and our staff around the difficult decisions that are required. But we are seeking to do this in a planned way to avoid going into recovery, which would have a more profound impact on the most vulnerable. So based on that context, the paper today is setting out a proposal for, I suppose, 2 key features in our planned approach going forward. Firstly, around how we actually identify and determine proposals, and the second around the underpinning engagement process that we're planning to support that. So in relation to identifying proposals, we plan to, in relation to identifying the proposals, a recommendation is based on previous discussions with the IJB in June around adopting an equitable approach to how we identify these. And this position reflected feedback we had from a range of stakeholders over 23-24, where some felt there was a disproportionate targeting of certain care groups. So in this basis, we're therefore recommending a 10% target is applied to the influenceable budgets across the breadth of our services and the care groups. And that 10% is influenced by the scale of the budget gap that we need to address. And we're also asking the IJB to approve our proposed engagement approach, which we've developed with Health Improvement Scotland to align with the recently updated Planning with People guidance. And we've had some really good conversations with HIS, and they have been encouraged by the approach that we're taking and the thought that we're putting into how we can make this process as meaningful as possible, but taking, I suppose, acknowledging the constraints that we're working with. So based on these discussions, we're suggesting a 2-phased approach that will align with the Planning with People guidance. In the first phase, we're looking to allow early representation of stakeholders to feed in to identifying ideas about how we can make the savings. And then in the second phase, this would be to engage with affected stakeholders when we've actually developed proposals. And the HIS guidance is very clear that before proposals go to the IJB for approval, we should seek the feedback of affected stakeholders, and that should form part of the approval that's taken to the IJB. So if approved today, the engagement process will start pretty quickly. We're looking to start that initial phase in early October, running through to early November. And there'll be 2 strands of activity that we'll take forward in parallel. So the first will facilitate a range of focus groups, and we'll use the existing care group planning structure, but we will, where we feel there's any gaps in the sort of representation of key stakeholders, expand the membership of those groups. And that's where we'll look to get views on how we can do things differently and where we could potentially make efficiencies. In parallel with that, we also plan to carry out a public survey, but this will be a sort of broader high level approach, just to test the sort of more general views and principles around how we address the gap and what's important to people. So the views of both from the care groups and from the survey will collate, and we'll put those ideas forward to the IJB at their your next meeting, and ask members for their view on which ones they would like us to take forward to develop into full proposals, which we would engage on after Christmas and before they come to the IJB in March. In terms of the engagement approach that we would take for the second phase, we're planning to have further discussions and develop that with HIS. So along with those ideas that we bring to the next meeting, we'd bring some more detail about how we think we could best hold those engagement sessions and get the views. So that's really happy to take any more questions on the approach that we've set out. In addition to the approach, we've also, you'll note, given just some updates and a range of ongoing project activity that's underway, but I can take questions on that, but don't plan to go through the details of that. Thank you.
Francis, I see there's quite a few hands up. I'll start with yourself, Fiona.
Thanks very much. Thanks, Francis, for a really thorough report again in terms of, I suppose, the situation that we're in. And I want to acknowledge how difficult this whole process has been for everybody, just in terms of the amount of savings and the gap in terms of financials that we have to meet, and indeed the change of direction, I think, and the impact of that on all of the workforce involved in terms of that process. I like the way that you're going forward in terms of this, and looking at what opportunities there are to look at a kind of more equitable share of those gaps, but I don't think that will be an easy process for anybody, so I want to acknowledge that right now. I do have a question just in terms of the restricted capacity that you mentioned in the report at 6.1, and it's really just a wee bit of clarification around about the sickness levels, because we have 2 different figures in the paper, one of which talks about the council staff sickness days of 19.51, and then it says that the NHS staff was 5.62%, and in my head I can't reconcile that one's in percentages and the other one's in days, so I find that the mixture of the 2 quite confusing, and it would be helpful for me if either they were both in days or they were both in percentages, if that's possible in any future. I also want to say that I don't underestimate the amount of work that this will require in what now is a relatively short period of time, and take the opportunity to thank the staff and everybody that's involved in this whole process, given the capacity issues, given the change of direction, and I just wanted to comment on that. Thanks.
Thank you, Fiona. Francis?
Yeah, in terms of sickness absence, unfortunately, this has been an outstanding issue since integration took place, where our partner organisations both present sickness in a different way. We have had a number of conversations about trying to get them both to percentages, but that hasn't been possible to date. So unfortunately, it's out with our control, and it has been a long-standing issue. We did look at converting the days to a percentage, but it's a bit more complex than that. So unfortunately, we're unable to provide a like for like.
Dave Francis. Yeah, I'll bring in Lisa Marie.
Thanks, Chair. Firstly, I just want to associate myself with Fiona's comments. I think they're all very valid, and I also support the kind of equitable approach we're taking, and that's very much been taken from discussions we've had at development sessions and at IGB meetings. Obviously, if I look at the second target in particular, and I'm not going to say anything I haven't said to officers, so I don't think this is going to be a scary thing for me to say. We discussed the 10%, and that number is sitting around the amount of money we have to save. But I suppose I wanted to reflect for people who are maybe listening and constituents that we've also talked about. Obviously, that's the target across the piece, but there might be services where you do less and services where you do a bit more based on what the impact of these services, and you have written that in the report a little bit, but I just thought I would reflect that, and that we know how stressful this is for people in offices, and we are really trying to look at doing it in the kind of easiest way possible, although none of it is easy. We want to have the least amount of impact we can on our people, and we really are working through this as much as we can. So I just wanted to reflect a wee bit more that we've had those discussions.
Thank you, Lisa Marie. I appreciate that. Right, we'll go to Alan. I believe you're next.
Thanks, Chair. It's maybe hopefully just to reassure the board in some respects that the relationship that the officers in Francis herself and Francis's team have built up with the local third sector in terms of provision, local health delivery through the third sector is very, very positive. And I suppose it's more a offer of support to Francis and the team in relation to engagement, particularly if she's looking at broadening out the church of people that she's wanting to get to reach. I'm pretty sure most of the organisations who are already close to the Health Social Care Partnership, and particularly in the SPG, would be very capable and up for supporting that wider engagement as it sort of develops. And on a personal basis, hopefully Francis doesn't need to hear this, but obviously if she needs me in any way to sort of help with that, then I'd be delighted to support where I can. Thanks.
Thank you for that, Alan. Again, it's appreciated. Ian McMillan.
Thanks, Chair. Here we go again. It's a horrible position that we find ourselves in. And I think if anybody's listening to this or reads any of the press statements, they'll be scared out there. People will be frightened what's going to happen to their services. People living in poverty, people who are vulnerable, people who are elderly, people who are in ill health. You know, it's a worrying time for them that their services are going to be cut. Let's be honest with you, that's what it is. The good old days used to be called efficiency savings, and used to be the money that you saved you could put into other services, but now it's just cuts. And some of the figures that are bandied about in this report in terms of funding gaps are truly frightening. Now, I'm not going to get involved today. There's other places for me to get involved in the politics of it all, but we are where we are, and it's ourselves as IGB members that are going to have to make these difficult decisions, and of course the staff that are going to have to deal with it on a day-to-day basis. And it's little wonder we'll get such high sickness rates. You know, the pressure the staff are under is unbelievable, trying to deliver these services. As we've heard, much more demands on the services and less money to spend on the services. So it's going to be a tough 5 or 6 months for everybody, particularly the people who will be affected by these cuts. I think it was hinted at somewhere else. As I say, I'm getting mixed up with all these different reports. It's what happens when you have the IGB the day before the full council all run into one another. I know the next meeting, I know we'll be looking at when the next meeting is going to be. It's in December, but I take it there'll be a couple of development days. And for people who are kind of new or maybe listening, these are development days when we don't make decisions, but we hear the nuts and bolts of what's going on and what the thinking is. So there will be at least a couple of development days, I'm assuming, before we move this any further forward in December. Right, thank you.
Hey, okay. Just to reassure you, there will be a couple of development days, Ian, before we go into any decision making. Colin, can I bring you in?
Yep, thank you, Chair. Probably just a few comments from me. I think this paper
blends in completely with the previous two papers that have been presented today. It links to the annual accounts position, which at least shows that position of strength in terms of that financial governance and stewardship in terms of the annual accounts position for the last financial year, but recognises that sustainability, and I think that's amplified through what's required within this report. I think the August position likewise clearly articulates where the pressures are. However, I think within that also shows through stewardship that path to break even for this financial year, albeit highlighting that that is going to really utilise the reserves probably to the nth degree in terms of where we are. Completely agree with other comments. There is no doubt that it is a challenging environment. There is no doubt there will be difficult decisions ahead of us as a board. And I think it's really important that we therefore adopt that early identification of the schemes where we can to ensure that that communication and indeed implementation when it comes to it follows through in terms of outcomes. So I think the process as it is outlined here is certainly an appropriate way forward, and what's wrapped around that with the other sessions in turn I think will be very helpful to the board in the coming months. So I certainly commend this in terms of a platform and way forward. Thank you.
Thank you, Colin. I really appreciate that contribution. Do we have any other questions or comments with regards to item 7? If not, then I'll move to the recommendations, and that is to note the current context programme positions set in section 3 and 4, approve the proposed approach to delivering savings equitably, including a 10% saving target set out in section 6, and approve the proposed approach to engagement to support identification for further savings set out in section 7. So if that's all agreed, we will move on to item 8, which is the performance scorecards. I believe that's back.
Yes, that's me again. So this paper presents the draft 24-25 HSCP performance scorecard for members' approval today, and it sets out the proposed changes from last year's scorecard and the rationale behind the proposed changes. So members will be aware that each year we review the scorecard to ensure that the performance indicators remain meaningful, and getting that balance between realistic and achievable targets, but also that retain that ambition and stretch. So the proposed changes to the indicators and some of the targets are set out in Appendix 1. I don't plan to go through those, but more than happy to pick up any questions around them. And then we provide the full scorecard in Appendix 2. I think just picking up on, I guess, the conversations that have preceded this in the other papers, the current context that we're operating in terms of the financing capacity is obviously a real pressure around our performance. And I think it's just to highlight to members that maintenance of performance going forward may be challenging, and that's reflected in the report. So as with previous years, if this scorecard is approved, we will bring it to the IJB twice over the year. We'll bring the mid-year report in January, and then the end-of-year report, which forms part of our annual performance report. The only final thing I wanted to just highlight was for members' assurance that we had an audit of our performance carried out in the last year, which was there was no audit findings, and provided reassurance around the arrangements that we've got in place. That's the only things, but happy to take any questions. Thank you.
Thanks for that, Frances. Do we have any questions or comments in the scorecard? Ian? Okay.
It's on page 147. Number of attendances at A&E. They've obviously went up quite considerably in the last year or so. Can somebody maybe tell me if there's been what research has been done on this, and any conclusions of why the number has went up quite significantly?
I'm sorry, I'm not aware of any research in terms of reasons for numbers. Obviously, A&E by its definition, like primary care, is kind of self-referred. People turn up themselves. I don't think people generally would be turning up to A&E at the moment unless they felt it was necessary, because everyone knows that the waiting times are really significant and the pressure the health board on the acute side are under. I do know that there is a redirection policy that's been applied to A&Es, which is effectively at the front door trying to identify those for whom A&E is not the most appropriate service at the time they present, and they are redirected to a more appropriate service, be that community pharmacy, be that general practice, or be that self-management or others. So I guess the attendance is only one part of the question. I think the admissions and length of stay and discharge is probably, and the flow through the hospital is probably as important. But certainly I know that there is a redirection in place now. So if there is a sense that people are attending and that is not the right service for them, then they are kind of highlighted in a more appropriate place to go, including primary care, be it dental, optometry, general practice or pharmacy.
Thank you, Stuart. Any other questions? No? Then I'll move to the recommendations. Okay, that's approve the HSEP's draft performance scorecard for 24 and 25, and note the full scorecard updating all performance measures will be presented twice yearly, January and June. Okay, and that'll form part of the annual performance report. So that's agreed. We move on to item 9, the Quality Care and Professional Governance Annual Report, 153.
Thanks, Chair. So in front of us is the Quality and Care Professional Governance Report from the time frame April 23 to March 24. It brings together the reports from all the governance groups in relation to the HSEP. And aims to tell the story of how we maintain our good governance and ensure delivery of quality services that are patient-centred, safe, effective and timely across the organisation. It provides evidence around that, and it also looks at some of the scrutiny that we have around some of our more significant incidents. So I wasn't going to go through this point by point. Is quite a lengthy report, and I hope members can see all the evidence in there and see the work that happens across the organisation. But I suppose there's a few points that I wanted to bring up. I've added in the structure to try and demonstrate the volume of work that happens across clinical care and governance within the partnership, and also highlighted that we're in the process of reviewing that structure, not necessarily to change anything, but to look at our terms of reference, our memberships and our agendas to ensure that we cover everything that absolutely has to be there and we don't have any gaps. And that work has been ongoing for the last 6 months and is probably nearing conclusion now. The other part that I wanted to pick up was around our incident management, because you can see there that there's been a significant increase in incidents. That doesn't necessarily give me a huge amount of anxiety. It helps us understand what's happening across each area of the organisation and gives us reassurance that when things do happen or go wrong in any shape or form, people are notifying that, and it gives us an opportunity as an organisation to address that and look at improvements. The top 3 categories in our incidents remain the same, which is self-harm, violence and aggression, and slip, trips and falls. But I think it's good to note that the volume of incidents in the NHS side of the business is much higher than those reported through social work business world. So sometimes that can be skewed slightly just by the volume. And that happens because social work services have other places to record incident management, which also comes through our governance group. What I've also added in is the work that's happened around those 3 main areas around minimising. So a lot of work has been done about risk assessment around slip, trips and falls, particularly as we move into the winter months.
and ensuring our staff are safe, as well as our patients and clients. And there's also significant work around managing violence and aggression and de-escalation techniques across all the services. And although there's an increase in self-harm and a decrease in violence and aggression, we think that's probably due to better and more accurate recording. And in relation to self-harm, we are absolutely seeing a huge amount of work, particularly around the ligature work that we've heard that's happening through mental health, but also through training and around risk assessments to support people who may be at risk of this. The other thing that I wanted to just notice is around our significant event reviews. And you'll see there's a whole raft of work that's happened over that time frame, with 11 being commissioned, 14 continued to be reviewed and in progress, and 12 closed. And I've added in some of the work around the themes of the improvement work around those closed SAREs, particularly around mental health, and in the district nursing world around management of pressure ulcers, which we went into in a bit more detail in the Audit, Risk and Scrutiny Committee. Throughout the report, I've given quite a large section to patient experience, not only about the complaints, but also that proactive report around what people are finding in the services. And I've tried to give a wide flavour of some of the compliments that we receive of people's experience of service delivery, which I thought was really quite important. And there's also a significant section in the background of good practice examples throughout each different area. I'm happy to take any questions. I also wanted to note there was a section in the mental health learning that I forgot to put in the abbreviate, or take out the abbreviations and put some further information on. So I do apologise for that. The abbreviations there that people might not be sure of is development of new system and processes such as alerts on EDC, that's early discharge decisions, and monitoring implementation and status of PIFU for community patients, and that's patient-initiated follow-up. So my apologies for people if they read that and thought I don't actually know what that means.
That's all. Thank you, Pauline, for a really comprehensive report. I believe I've got a couple of questions here, and it's Ian McMillan first.
No, thanks very much. Very good report. Enjoyed reading that. But just want to comment on the feedback. I found that absolutely terrific. That's what we want to hear. We want to hear real examples of how people are getting on with the service, how they've been treated and all the rest of it. I think that's really, really, really good. And a lot of this stuff to me it's not a health person. It's fairly technical, but when you read people's experience, it kind of brings it home. So I'd like to thank you for doing that. And I know some of us probably am guilty than most people tends to concentrate on the negative aspects of things getting on, but I think it's worth recognising as despite the challenges that we face, there is some really, really good work out there every single day by a lot of people. So thanks for that.
Thanks, Ian. Okay, Lisa Marie.
Thanks, convener. I agree with everything Ian said, and I'm just about to ask quite a technical question. So in terms of the incident management reporting and investigation, you referred yourself to the fact that some of that you would think would be better reporting, and I think that's hopefully true, because I think all of the organisations involved in the services that we deliver are constantly working towards better reporting, but given it's like a 50% increase, it's not all going to be that. I wondered if we've got any sort of rough idea of how much of that is just better reporting and how much of it is actually significantly more incidents, like when we're working towards processes to make reporting better. Have you got a target in terms of how much more you think you might get?
There's no target in relation to incidents. I suppose our target around our incident management is ensuring the governance is good and reviewing them. So a lot of the incidents that are reported are very, very, very minor and negligible and can be closed off quite quickly. I think the other thing that we need to be mindful of is we've got now the Health and Care Staffing Act, which is enacted. So we're encouraging, if there's any staffing issues, to be reported through that as well. So that's not all the hike, of course it's not. It's very, very variable. We
do see spikes in the winter. We do see spikes, but it's particularly around slip, trips and falls, and that is one of our main ones. But I think through all the governance group and the review, we've been speaking about incident management a lot over the last 6 to 12 months, and really, making sure that if something's informally noted, we're saying, have you recorded that? So it's an awareness of a picture, and that picture, I think, will tell a story as we move forward, and I'll probably be able to answer more of that question as we move forward with this, but just not quite at the moment.
Thank you, Pauline. Okay, if there's no other questions or comments, I'll move to recommendations, and that's to note the contents of the report, so appendix 1, and to note the number of examples that are included within the report, but not limited to. Okay, agreed? Let's move on to item 10, which is the mental health service update. Yourself, Laura.
Thank you, Chair. So members will recall that the IGIB approved Greater Glasgow and Clyde audit adult mental health strategy refresh 2023 to 2028 at its meeting on the 23rd of November of last year. So this report provides further detail on the next stage of the implementation of the strategy and information relating to the aligned public consultation. So I don't plan to go through every aspect of the report, but for members' awareness, I would just want to highlight some key points within the paper. So section 3 of the paper outlines the background to the strategy, detailing the four key aims, which are to deliver prevention and early intervention, improve the effectiveness of community services, develop unscheduled care, and develop the focus on recovery. So the vision and case for change within the strategy recognises that providing more mental health treatment and care in a community setting rather than hospital leads to better outcomes for people using mental health services. Currently, for information, there are approximately 1,000 mental health inpatient beds across NHS GGC, and Renfrewshire has 140 inpatient beds across 3 sites that you will be familiar with, Dyke Bar, Leverdale and Royal Alexandra Hospital. In terms of the strategy, over time and with planned expansion of community services, this could be reduced to approximately 800 beds with an increase in inpatient care for some specialities, and that would focus on specialities like eating disorder and young people mental health. So the main new or expanding proposed community developments or based developments are highlighted in section 3.4 of the paper, and development and implementation of community services expansion will be directly linked to the phased retraction in inpatient beds. Each phase of community development will be dependent on a shift in resource to the community as and when the inpatient retraction is delivered and has taken place, and the investment in community will follow on from that. Section 4 of the paper outlines the robust 3-phase public engagement process being taken forward by NHGGC and the 6 constituent HSCPs. The approach, as we've heard earlier in earlier papers, is similar and has been developed in line with the Planning with People, community engagement and participation guidance. Phase 1 of the process is complete and output is attached as an appendix to this report. Phase 2 is currently underway with 3 of the 4 in-person events having taken place already this month within Renfrewshire. And feedback so far has highlighted the feedback has been aligned with the aspirations and intentions of the strategy that are further outlined within the paper. So happy to take any questions that anyone might have.
Okay, thank you, Laura. Do we have any questions? There you go. I think you're off slightly there, Laura. So just wait online, make sure. Yep. Okay. No questions or comments. So we move to recommendations, and that's to note the progress of the implementation of the NHS GGC mental health strategy for 23 to 28 and aligned consultation process. Okay, agreed. That takes us on to Renfrewshire's Alcohol and Drug Partnership annual reporting survey.
Thank you, Chair. The report that the board members will see is actually laid out by Scottish Government. It's actually done as a survey, which has got some limitations. I think I remember maybe saying this when I came last year to give an overview of this. So the report's there, it lacks performance and outcome measures. So what I would like to do, if it's at all possible, is have the survey there for members to look at. Happy to take any questions on it, but maybe highlight some areas of activity that we're undertaking within Renfrewshire at the moment, but also link into that some offers to the IGB about how they would like the ADP to report in terms of some of the ADP activity over the coming months. The ADP has its own performance framework, and that performance framework reports into the ADP executive meeting on a quarterly basis. So again, there's an offer there to the IGB about how they would like to see, or would they like to see, that performance framework, and if so, I'd be very happy to bring that back in a reporting format. Similar to the ADP exec meeting itself. As part of that performance framework, the ADP has undertaken a needs analysis within Renfrewshire. That was one of the gap areas that I identified when I came into position as the independent chair, that the Renfrewshire hadn't had a needs analysis in terms of its alcohol and drug provision across all partner agencies. So although we were doing much of the things that every other area in Scotland were doing, the question I was asking ADP members is, are we confident we're actually targeting the areas that we wish to target? And those questions, I think, are even more relevant when we talk about the financial pressures and we talk about the challenges we have in terms of the things that's come up in the meeting earlier on today. So in terms of some of that needs analysis, I'd like to highlight a few areas that have come through, and again, happy to take any questions and any discussions around those areas. So some of the developments that came from the needs analysis is the lived experience part of the ADP. Again, that was an area of gap that we had in terms of the ADP structure, that we had little in the way of representation for those individuals with lived experience themselves and family members. I'm happy to say that the ADP exec now has membership with lived experience and representation from family groups. And this has been identified by Scottish Government as an area of excellent practice in terms of a number of other ADP areas that do not have that as yet. So there's been discussion with Scottish Government about the ability for Renfrewshire to progress that and how other ADP areas should follow suit. Also within that is how we gather data and how we look at data surveillance. We have established a number of data surveillance processes within the ADP, looking at alcohol harms and deaths and drug harms and deaths. It's already been mentioned that we have established two positions within the ADP, that of alcohol death prevention officer and also a temporary 1-year position of alcohol prevention officer. Again, that's to allow us to understand the figures that members were raising earlier on, and to understand what is the activity we hope to undertake that might give us some reassurance that we're actually doing something positively to maybe reduce harms and deaths in the future. My concern sometimes is that as the independent chair of the ADP, you know the staff are working very hard, you know partners are working very hard, but you never feel overly confident that the figures the following year are actually going to reduce. And that's always been my concern. So the big question, and hopefully it's not an impossible question, but the big question the ADP has to set itself is, what can we do differently? And what do we hope those differences will actually make? So that is the question that ADP members have been looking at in the exec over the last period of time. Linked into that work is obviously how we ensure we've got very strong prevention in the early intervention services. So again, we have got really robust treatment and care services, which under the management of Laura Howitt. But ideally, we want as few people to be going to those services as possible. So how do we have the best prevention and early intervention? The ADP is very keen that we have to adopt that alcohol and drug business is everybody's business. It's just not the business of alcohol treatment and care services. By that time, the damage is done for a lot of the individuals. So what's the whole population approach that all provision and all partners should undertake So the ADP is having extensive conversations about how we look at that. Linked into that is really where we believe stigma has a really important part to play. And the ADP has, in partnership with the Paisley Daily Express, looked at how we look at a stigma campaign and how we get into a wider conversation around stigma. The concerns I have with stigma, and it's linked into the conversation of financial savings, and I'm sure this wouldn't happen in Renfrewshire, but I always worry about it, is you then get those individuals who are very vulnerable, but not always the most worthy. And sometimes conversations begin to take place about who are the most worthy individuals and who are not the most worthy. And that concerns me. And I think it's something we need to ensure is not a conversation that we have in Renfrewshire. But if that conversation does come up, we're able to respond to it, because those individuals are sometimes our most vulnerable individuals. And that's something that we need to be looking at. Linked into that is how we look at our harm reduction measures. And obviously Renfrewshire has developed its HARP team, which I think the board members will know about, the Mobile Response Unit. And we're looking at how we actually extend that provision over the coming months, and the model of how that provision is developed. But again, hopefully members will have seen the HARP response team in their area. And again, if there's a requirement for a response team to be in that and in an area it's not there, then there's a process through the HSCP that we can actually make that happen. The other thing, hopefully, that maybe members had seen over the last few weeks is we had a fantastic overdose awareness event, which the community had a really important role to play, and we had a service of remembrance within the Paisley Abbey. So again, that's areas where we want to ensure we raise the awareness in terms of the challenges we have, especially around drug deaths in Renfrewshire, and equally around alcohol deaths, which are always more concerning in terms of the actual numbers itself. In terms of challenges going forward, the challenges are always going to be the case of the financial challenges that we have. Although at the moment the funding that comes from Scottish Government, there's a protective factor in terms of alcohol and drug provision. The funding model from Scottish Government is in a very short-term basis. So the big challenges in terms of alcohol and drug provision is what happens post-2026, when the funding structure becomes uncertain in terms of ADPs, because at the moment there is no guidance in terms of what the funding pot will look like for alcohol and drug services. So again, the conversations and the challenges that all ADP chairs are having is, if we want to plan significant change for our populations and try to have some degree of safety net, we need to have a better understanding of what the actual financial package will look like after 2026. How do we embed services that actually need to make an appropriate change if we don't know what that funding will look like? So that's an overview of some of the work that we're actually undertaking. The proposal I'd probably like to put to yourself, Chair, is how you would like the ADP to report into the IJB. Would you be wanting to see the performance framework in terms of the ADP? And I would be keen, rather than just coming once to give the report in terms of the annual survey, as we have more of a regular input from the Alcohol and Drug Partnership around the areas that the board members might find of interest. So happy to take any questions or comments.
Absolutely, John. There's so much of what you said rings true there with me. I'd actually written down that I really would appreciate, what it'd be an idea maybe for you to attend one of our development sessions, John. You can bring the framework and we can add that to the agenda. I would appreciate that. You're so right with regards to stigma when it comes to recovery. I think one of the breakthrough days we had here was when we actually hosted the recovery walk in Paisley, and it was right at the town centre, and it really was out in the open, so that, because it's breaking down those barriers and allowing people to come forward and seek the help that they desperately need, because, as I say, a lot of times they're scared of the ramifications that come off the back of that. Right, thank you, John, and I would appreciate if you attended our next development session. Right, there is a few hands here. I'll move to Lisa Marie first.
Thanks, convener. I feel like as John spoke there, I was gathering things in my head I want to say, so I'll try to keep it short. First of all, thank you for the report, John, both in terms of the survey, which, although as you said, it has its limitations, there's an enormous amount of detail in there on the work that you're doing, but your report has filled that out for us, and I really appreciate that. I would really welcome your performance indicators coming to board as well. I think it's really important. This is something we need to be on top of. And I suppose what I want to reflect through both the paper and what you've said today is that I think every one of us in this chamber feels, and teams, because they're not in the chamber, feels that every single death is a tragedy, and we never want to see the numbers going up. Although, as Christine reflected earlier, some societal issues are large events may impact in that. We never want to see it, but I think it's important that people see the enormous amount of work that needs to be done. And of course, we want to see numbers going down every year. I think everyone in here wants there to be no deaths. But I think some of this work takes a bit of time to bed in and to actually impact in people's lives. And I think your point about early intervention is really important, because the only way we're really going to solve this is through earlier intervention, essentially into childhood for societal change. I think so much of health improvement is about supporting young people to understand life choices and to understand things, and providing that support so that they don't get into the position where this might be I suppose the only way out for them, or they begin to self-medicate, or people get into addictive cycles anyway. It's such a complex thing, but it is something we really need to focus on, and I've just really welcomed your report, and I would love to see more. And I think the convener's suggestion that we have something brought to one of our development sessions is really good. It allows us time to really get into kind of the meat of the information, and I think that's valuable for all of us, particularly when we're making tricky decisions, so that we know what the impact really is. So just thank you for your report.
Thanks, Marie. Ian.
Yeah, very good report, John. It's a pleasure listening to you as usual. I think, again, get back to lived experience, that's a big factor. You know, when I've been at various meetings and forums, and you hear somebody firsthand the experience they've had through either alcohol and drugs, and the impact it's had on them, their health, and their families and loved ones and friends. It really rams home what the impact alcohol and drugs can have on people. I think obviously we all know that this area has a huge problem with alcohol. You see it every day in our town centres, and you know, I think I've said before that you can hardly go to an event nowadays when folk just want to have a drink, whether it's a football match, whether it's a wedding, a christening, Holy Communion, whatever it is, people all seem to be getting drunk, and I think that's pretty sad, to be perfectly honest with you. I think we have to it's good that we've had this offer of development days and more reports. I think the effect of alcohol and drugs is so large in our society. It's not something we can have, you know, every year, just a report, and you look over it and then we move on to the next thing. I think it's something we need to face on a more regular basis. And I have a lot of sympathy with what John said there in terms of the work they do. The work they do and it is absolutely amazing. However, there is that crossing your fingers and hoping for the best that people are not going to pass away. And that's quite sad. Also noted that the rise in deaths from cocaine. I think I've spoke at this forum before about my concern about the more common use of cocaine. You see people on the street using it, you see people at football matches using it, and you get into pubs and clubs and you see it as well. It's not a drug of choice for the elite now, or the trendy away out the road. It's commonplace. Really, and you're standing at a football match and there's people bending over and taking cocaine. You're like, what the hell is happening? It's absolutely awful. But as I say, I welcome the report, and as I say, I think it's something we really need to face up to in the years, in the weeks and months ahead, because it's a huge problem for us here, not only in Renfrewshire but whole of Scotland. Thank you.
Fiona.
Also, I suppose to reiterate, I welcome the report, John. Really helpful. But in addition to that, is your comments that followed that, where right away my brain's thinking, I need to know more about that. We are making decisions about these services, and there's far more I think that we need to take on board. And the introduction of yourself to do some help at the development session will be really crucial to that. Really pleased, I suppose, to hear the progress that's been made in terms of the inclusion of people with lived experience. That's, I mean, really what we learn from people. For those of us even who are providing services who may never have been in that situation ourselves, we need to be able to hear what's going on there. I liked what you said, in particular around about your approach about reviewing the gaps, because if we keep doing the same thing all the time, we're going to keep getting similar outcomes in terms of that, and looking at the learning so far as part of the service of provision that we're providing just now, but also if we can address what those gaps are and include them in planned work going forward. And your comments also about the kind of whole systems approach. You know, people with issues in terms of their substance misuse does not just sit with that person and they're on their own. You know, their families are affected, the communities are affected, and therefore we are all affected. So it is everybody's business in terms of that. We've got children being brought up in families where this is normal for them, this process. So we do need to be thinking about how we educate, how we look at early intervention in terms of that. I would be really keen for your performance framework to come to ourselves so that we can get, I think, underneath the kind of issues. Our report's really great and it's helpful to have all of that, but the work is so intense and so required. We're looking at the figures here earlier on of what was reported, both in terms of drug use and alcohol use in the area. So I think there's a lot more work we can do with the input of yourself and the team and the ADP. So thanks for the report, but it just makes me want more information to make sure that if I'm in a situation where I'm making a decision, that I'm doing it with the best information I can. Thank you.
I see Laura, you got a hand up.
Thank you, Chair. Just two things for me. One was in relation earlier on to yourself, Councillor Riley Nicholson, when you spoke about benchmarking, just to pull out in terms of Renfrewshire's benchmarking against the MAT standards. We're benchmarking very well and progressing very well out of the 10 standards, and one has turned to blue, which means it is sustained, which is a very, very positive position. So in the midst of all the work and challenges, again, reflecting on some of the very positive work that's been taken forward. The second is for members and boards awareness, just around some increased activity. We had planned a harm reduction campaign earlier on in the year, but it was postponed due to the elections. So it's now taking place between the 7th and the 11th of October, and there'll be a whole range of activity going on within Renfrewshire at that time. And also there will be an open day at our ADRS service base, which is currently in Backsnedden Street, and that will be open for all to come along and hear information, meet people, and get access to a whole range of information about the services available within Renfrewshire. So it is open to everyone. I would encourage members of the board to come along and meet people and connect with a lot of the activities that are taking place. So I will ensure that that information is circulated to board members afterwards. Thank you.
Okay, thank you for that. I would like, before I move to the recommendations, I would just like if we can actually take it as an action to include John in our next development session and to include the framework within our agenda. So, oh, sorry, John, your hand's up.
Yeah, thank you. It was really just to maybe make two further comments. So first comment really just to say that the ADP's overview of its treatment and care services is, to give reassurance to members, Renfrewshire's got some excellent treatment and care services and are on par to any other ADP area nationally. So I think we should take some degree of reassurance in that. What the ADP is really keen to do is how we look at that whole population approach. So we can have the best treatment and care services anywhere, but if we don't have all provision across Renfrewshire understanding what their responsibilities are to alcohol and drugs, then the treatment and care services are never going to be big enough to deal with those people at the far end. And just the final thing is really just to say is, again, when I come into the ADP post, we've done a reset of the ADP, and it's just to put out a request again, if there's any interest, that I would be very keen to have some local elected member representation on the ADP. And again, it's just through the IJB to put that offer out there. If there was any local elected members who would wish to be part of the ADP structure, then very happy to put that offer on the table, Chair.
I would, John. I would like to be part of that. So you can count me in, unless somebody else wants to have a vote on it. No, okay, John, looks like you've got me. That'd be great.
Excellent, thank you.
Right, I'll move to the recommendations if there's no other questions or comments. Okay, so that's to note the contents of the survey and approve the annual report survey. Okay. So that's agreed. And that moves us on to item 12, which is market facilitation plan and communications update. Commissioning, sorry, update. Pages 231 to 236. Thomas, would you like to go ahead?
Thanks, Chair. Yeah, so an update for members on the market facilitation plan and just a brief overview of planned commissioning and procurement activity this year. Members will recall the market facilitation plan was brought to the IJB in June of last year and approved thereafter, was published. Just as a reminder, a market facilitation plan is a requirement on the IJB under the Joint Bodies Act. And I guess the purpose of it, to help shape the social care marketplace, make sure that we've got the right services available for the population. Also gives really relevant information to provider organisations in terms of helping them make informed decisions about their ability and capabilities to work within Renfrewshire based on our needs. So an update really to say that the plan so far it's from 2023 to 25. Over the last year it's been immensely useful for the contracts and commissioning team in terms of our discussions with national organisations. Particularly those who don't currently have a foothold or a footprint within Renfrewshire. The fact that it's a single point of a single source of information has been useful to us as a team and also useful to, like I say, prospective organisations. We included quite a lot of demographic information in our market facilitation plan last year, most of which was in the public domain, but perhaps quite disparate in terms of where it was located. So bringing it all together to a single source has proved useful for organisations. Throughout the plan, we have a commitment to ethical commissioning practices, and it's really just to update members that we remain part of that national conversation on ethical commissioning, which continues, and more locally, continue to have a strong commitment in terms of engagement with organisations that we contract with, who we see as valued partners in terms of helping us meet our strategic aims and objectives. So section 5 of the report, which gives a bit of an update on procurement activity and planned and awards that have been made this year already. This is all information members will be aware that's in the public domain already in terms of the contracts register on Public Contract Scotland for Renfrewshire. I'd probably not go through them all one by one, but draw your attention to the flexible framework for supported living and community-based support services. Just to update you, that was approved at the Council's Finance, Resources and Customer Service Policy Board on the 12th of September. We're now in a standstill period, and the intention is that framework will commence on the 1st of November. That's a very, very positive step for the HSCP in terms of growing that marketplace. The supported living community-based supports framework is primarily for adults under 65, LD, mental health, physical disability, and we're really pleased to have increased the number of organisations on that framework that we can work with. And maybe just finally drawing members' attention based on the conversation earlier about alcohol deaths, you'll see an award there to RCA Trust, which was made this year, which, you know, kind of confirms our commitment to working across the piece, not just at the treatment end of the scale, but a more community-based open referral system and service. So just welcome any questions from MD on the report.
Okay, thanks for that, Thomas. Do we have any questions or comments? No, everybody's in agreement. Okay, so we can...
Sorry, Chair, can I come in? Sorry, I put my hand up.
Sorry, Alan. Sorry, I never saw you online.
Thank you, Chair. It's really just to know, obviously, there's a substantial amount of sort of contract here with the third sector, so I'll be interested to see particularly the low-level preventative health and wellbeing services, how that is service reviewed and what the outcomes of that are, along with obviously potentially the community link workers being extended. So I'd be interested, obviously, in further information as that develops. Thank you.
Sure. Thanks for that, Alan. Fiona, did you want to come in? No? Sorry for that then. Right, okay then. So can
Alan had his hand up, sorry.
No worries. So can we agree to note the report? Agreed. Max has already given us a verbal update with regards to audit risk and scrutiny. I think there's anything else needs to be dealt with that. So that would move us on to item 14, which is the date of the next meeting. So, okay, Mark can come in.
Thanks, Chair. It was just to draw members' attention that there is actually a specific decision required here. The current date that's scheduled for the meeting is November, and there's a request to move it back to December. So it's not simply for noting, there is actually a decision to be made.
Yeah. Okay, and that's obviously to allow more time for the initial engagement in the Sustainable Futures programme. So we all realise how important that is, and we agreed to postpone November's meeting to reschedule for December. Agreed. Okay, that just leaves me to thank you all for your attendance here this morning. Thank you and goodbye.